Hello, I'm Nancy Rowe from Rush University Medical Center, and I'm the current WGO chair of the Hepatology Interest Group. We have a series planned for celebrating World Hepatitis Day, and the first of our series is going to cover hepatitis delta. I'm very pleased to be joined by my colleagues Alice Lee and Cecilia Cabrera, and we're going to cover the spectrum of hepatitis delta today for you.
Hello, everybody. My name is Cecilia Cabrera, and I'm a pathologist and gastroenterologist from Hospital Guillermo Almenara in Lima, Peru. And I'm starting with this webinar, Developments in Hepatitis D, with the topic Epidemiology and Risk Factors. For introduction, hepatitis delta virus is a defective RNA virus that depends on hepatitis B envelope protein for transmission and replication. No HDV infection is possible without hepatitis B virus. But is hepatitis D a rare disease? In this map, we can see a worldwide prevalence of delta virus among HBs antigen positive individuals. As you can see here, the highest numbers for prevalence are in Central Asia, especially Mongolia, which this is in red, with more than 50% of prevalence, followed by India, China, Pakistan, Middle and Central Africa, especially the sub-Saharan areas, Eastern Europe, for example, Republic of Moldova, Romania, Pacific Islands. In South America, we can also see endemic areas in the Amazonic basin, which includes countries like Brazil, Colombia, Ecuador, Venezuela, and my country, Peru. The lowest prevalence is seen in Central Europe and in North America. But what are the real numbers for worldwide prevalence of hepatitis D? Recently, it has been published 3 large meta-analyses on this topic. The first one by Dr. Chen in 2018, the other by Dr. Miao in 2020, and the last one by Dr. Stockdale in the same year, 2020. And they reported for HDV prevalence in global population, Dr. Stockdale reported 0.16%. while Dr. Chen and Dr. Miao reported 0.98% and 0.8% respectively. And we will look the HDV prevalence in HBs antigen positive population. Dr. Stockdale reported 4.5% of prevalence, while Dr. Chen and Dr. Miao reported 14.5% and 13%. This means that for this report, for this study, we have 12 million infected people with Delta virus, while with this other study, we have more than 50 million infected people, like HIV or hepatitis C infection. Despite the difference in methodology in these 3 studies, how can we have so much difference in numbers? And maybe that is because of the highly variable HDV distribution that makes it too difficult to estimate true global prevalence for this virus. To give you an example of this, let me show this paper by Dr. Cabezas and Dr. Braga that study a population in the Amazonic basin between Brazil and Peru, and which is an area that is endemic for hepatitis B. And in this study, the HDV seroprevalence in HBs antigen positive population went from 0, 30%, 66%, and to 80% prevalence of Delta virus. While the whole seroprevalence of this virus in all the country named Peru or Brazil was less than 10%, less than 1%. 8 years after, the same Dr. Cabeza reported in this same area that after a very restricted program of hepatitis B vaccination, the HDV prevalence declined to less than 10%. So we have so much variation, and this scenario repeats in other places like in Asia and Africa. HDV global epidemiology is changing. We have factors like implementation of vaccination against hepatitis B, safer sexual behavior due to HIV infection, more availability of disposable needles and syringes all over the world that contributes to a decline in HDV prevalence. But on the other hand, we have immigration from endemic regions to high-income countries, especially since 1985 so far, the lack of universal HDV screening in chronic hepatitis B, poverty, poor access to HDV therapy, and all of these factors have led HDV to persist in endemic areas and in high-risk groups all over the world. What about HDV genotypes? There are 8 different genotypes in different regions and are associated with different clinical outcomes. HDV genotype 1 is the most widely present in all continents, that includes Central Europe and North America, and is associated with mild to severe hepatitis and rapid progression to cirrhosis and hepatocellular carcinoma. Hepatitis, this genotype is seen here in this map in light blue. We have also genotype 2, that is in Russia, Taiwan, and Japan, and is associated with a milder disease. We have genotype 3, here in black, in South America, in the Amazonic basin, which are associated with much numbers of fulminant acute hepatitis, more death rates, and possibly more responsiveness to PEG interferon therapy. We have here in light brown genotype 4 that is almost restricted to the Far East, and genotype 5 to 8 that are all in Africa, and we have not clinical data about them. Let's say a word about HDV natural history. There are 2 infection patterns that provoke different outcomes. The first pattern is co-infection, that is when Delta virus infects simultaneously with hepatitis B. And in these cases, we have in a full recovery in more than 80% of cases. The second pattern is superinfection. Superinfection is when hepatitis D virus infects a person who have already chronic hepatitis B. And superinfection is more likely to develop persistent infection, leading to accelerated progression to cirrhosis and hepatocellular carcinoma. As you can see, the difference here is almost 80%. And when you have this co-infection, HDV infection is dominant in most cases, nearly 70% of cases. So in the same way, recent studies have shown that HDV leads to rapid progression to severe liver disease in patients with hepatitis B. It has been reported that HDV, HBs antigen positive patients faster developed cirrhosis and hepatocellular carcinoma in 5 and 10 years respectively. We can see also that HDV causes 18% of cirrhosis and 20% of hepatocellular carcinoma associated with hepatitis B. That means that 1 of 6 cirrhosis cases and 1 of 5 hepatocellular cases associated with hepatitis B also have Delta virus. And finally, HDV infection has an increased risk of HCC compared with HBV monoinfection. So Delta virus jeopardizes the outcome of the hepatitis B infection. What about transmission of HDV? The primary route is parenteral, but intrafamilial spread is reported in endemic regions, and perinatal transmission is not a major route. So taking into account that Delta virus is transmitted primarily by blood or body fluids, we can identify groups at increased odds of HDV infection. As you can see here, people who inject drugs, commercial sex workers, men who have sex with men, hemodialysis recipients, HIV population, hepatitis C virus infection, patients with liver disease like cirrhosis and hepatocellular carcinoma, in which we can see more prevalence of Delta virus. And it's not shown here, but population from hepatitis B endemic regions are also at higher risk for Delta virus infection. Migration has determined specific groups at higher risk of HDV infection. People who inject drugs and HBs antigen positive is currently at a high risk group for HDV infection. Studies report a rise in HDV seroprevalence in this special group. For example, in US, HDV prevalence rise from 29% in 1988 to 50% in 2005 in this special group of people who inject drugs. And in this very same group, in the group of co-infection with HIV and HBV, the HDV prevalence was 14.5%. The triple infection of HDV, HIV, and HBV have 6-fold risk increase for hepatocellular carcinoma. And the triple infection of Delta virus, hepatitis C, hepatitis B have more aggressive clinical outcome. And commercial sex worker and men having sex with men show also high HDV prevalence in certain regions of Asia and Africa. So take-home messages. Seroprevalence of HDV is highly variable, but at least 4.5% of HBs antigen positive individuals are infected. HDV is strongly associated with higher risk of cirrhosis and hepatocellular carcinoma progression. Implementation of hepatitis B vaccination, universal screening in chronic hepatitis B, and better socioeconomic conditions are associated to reduction of HDV prevalence. People who inject drugs, commercial sex workers, men who have sex with men, chronic hepatitis B carriers, and co-infection with HIV and HCV are risk factors to HDV infection. And finally, I hope that I could show you that HDV infection is not rare. It's a global health problem, and we must be aware of it. Thank you.
Hello, my name is Alice Lee, and I'm a professor of gastroenterology and hepatology in Sydney. I work at Concord Repat Sydney Hospital in Sydney, and I'm an associate professor at the University of Sydney and also a professor at the Macquarie University. My interest lies in the development and implementation of viral hepatitis programs in the resource poor setting. Today, I'm going to spend the next 10 minutes or so sharing with you some of the screening and diagnostic algorithms for Delta hepatitis. Just as a recap in terms of the virology, as you remember, Delta hepatitis is a single-stranded RNA virus, and it has a 1,700 base pair circular genome and is smallest of the animal viruses. It's unique in that it does not have its own envelope and requires a hepatitis B virus. The Hep B virus envelope allows it to enter and exit the cells. There are two forms of the Delta antigen, the S and the L antigen, and it replicates within the host cell using the host's enzyme structure, as it lacks any protease or polymerase enzyme activity of its own. So what are the tests that we have available to us for the purpose of testing for hepatitis D? As I mentioned earlier, there is a Delta antigen, and this tends to occur early but disappears quickly. And then you have the anti-Delta, both the IgM and the IgG, and they do behave in a slightly different way. But the most helpful of them is the total antibody level, which is a combination of both the IgM and the IgG. And of course, we do need to have confirmation of viremia with a viral load testing in terms of the Hep D RNA testing. What about the genotypes? We know that Delta hepatitis is a highly variable virus, and there are at least 8 genotypes that are known. Genotype 1 is universal, with the other genotypes that are seen in different distributions throughout the globe. We're not entirely sure as to the implications of the genotypes, but there is increasing data that there are differing natural histories as well as potential role in determining response to therapy as increasing numbers of treatment options become available. This is a slide to summarize the natural history of Delta infection. On the left, we have cases of co-infection when both the hepatitis B and the Delta infection occurs at the same time. And in this cohort of patients, what you see is the antigens occurring together, and the antibody to Delta occurs in the IgM, which then disappears, and then the IgG then follows thereafter. The viremia is brief, and in most cases, the co-infection can lead to clearance of the virus. If Delta occurs in the setting of superinfection, in other words, the person is already infected with B, and then the Delta infection occurs at a later date, the antibody levels do tend to rise, both the IgM and the IgG, and they both tend to persist. The antigen for Delta tends to be very brief, with viremia continuing in context of chronic infection. So this is another summary of the variable lab diagnosis that we might consider in determining what phase of infection and in trying to assess someone who has Delta hepatitis. Of course, the first thing is that because of the requirement for the surface antigen for envelope, all patients have positive surface antigen. In general terms, the use of the core antibody, IgM, is determinant as to whether this is an acute infection or whether this is a super or a chronic infection. The use of Delta antigen is quite complex and is probably not to be used in routine practice. And as I showed on the previous slide, it tends to occur early and is short duration and then disappears. Viral load testing for Delta determines whether someone has ongoing chronic infection. And the two antibody testing for Delta, the IgM and the IgG, tends to go up together and tends to stay high over a course of time. And of course, it's not routine practice, but you can have the detection of Delta antigen within the liver cells if patients are then deemed to be appropriate to have a liver biopsy. So let's move on to who should we test and how do we do this? Now, the testing rates for Delta is generally very low. And despite the variable guidelines with various degrees of recommendation on testing, it's considered that rates of testing is much lower than what the guidelines suggest. And in some studies in the US back in 2015, less than 10% of patients were tested for Delta. This is probably a little higher in Europe, where less than 50% of patients with hepatitis B have been tested for Delta as well. So in concept, there are two broad categories, whether you do universal testing or consider at-risk group testing. So the European guidelines recommend that all patients who have Hep B be tested for Delta at least on one occasion. And this may in fact be the simplest way for us to proceed. The Yapali guidelines is a little more generous and recommends testing of patients who have chronic liver disease and hepatitis B, and the AASLD guidelines are a little more complex and talk about identifying those at risk that we already heard about, and then testing those cohort of patients. Of course, the other conundrum is, what do you do if you test your patient and they're negative? Whether it's the antibody or the viral load, when should you retest, and what are the indications for this? So our recommendation is that the simpler the algorithm, the more likely that it will be implemented. So the first test that we recommend for all patients is a Delta antibody. The current widely available assays is the immunoassay, but it does have a range of complex issues. It's not standardized, and there is some variability in sensitivity. And of course, not all areas where there are high rates of Delta have assays access, and the cost can be prohibitive. Once you have a positive antibody titer, we do need confirmation this is consistent with chronic infection by confirming viremia. And in this sort of scenario, we have shown in different studies that the rates of viremia can vary quite markedly, and this is also regional dependent, and the viral levels can fluctuate. The assays itself have various degrees of sensitivity and can be quite complex, including difficulties in extracting the nuclear material. And again, as usual, the cost and access issues need to be considered when making recommendations. So we know that there are high rates of Delta, particularly in the areas where they don't have good resourcing. And hence there has been some great progress that have been made so that you have increased access to diagnostics. Point of care testing has been available for both hepatitis B and hepatitis C. The rapid test kits and the viral load testing has really ensured that we've been able to deliver treatment and care guidelines to some of the more difficult areas. More recent development in the rapid diagnostic test for Delta hepatitis has shown that the kits can actually deliver high rates of sensitivity and specificity with up to 100% specific rates. And here you can see some of the results that have been shown in these studies that was published in 2021, where you can test for both Delta antibody as well as the presence of surface antigen. These tests remain very promising, and we hope that we can see this offered at a cost-effective way with ongoing access to reliable testing. Of course, we also know that dry blood testing has opened up an entire world of diagnostics for patients with hepatitis C as well as for HIV. And there have been some studies that also confirm its value and its applicability in the diagnosis of viremia in patients with Delta. And the simplicity is the finger prick test with a drop of bloods on a special blood paper, and then it can be posted so that if the resources are not available locally, then viral load testing can then be done off-site. I mentioned earlier that the prevalence of those with positive antibodies that translates to positive viral load does vary from region to region. And as you can see in this particular meta-analysis, the rates vary between 40% in the Africas to over 70% in the Western Pacific. So it's really critical that those who have a positive antibody then have a subsequent test to confirm whether they have chronic infection or not. So in my final slide, I would suggest that we recommend all patients who are Hep B surface antigen positive have at least one anti-Delta during the course of their illness. Hopefully, with increased access, this may be possible through rapid diagnostic tests, particularly in areas where access to formal immunoassays is not available. If the test is negative, of course, they should then be linked to standard of care for Delta hepatitis. For those who have a positive antibody result, we recommend a reflex viral load testing. Of course, this is not currently available widely, but perhaps with the increased ability for us to utilize dry blood samples, perhaps this will become easier for us to implement. With a positive viral load, then that patient then should be linked to care and assessed for eligibility of treatment. If the viral load is negative in the presence of a positive antibody, then they should be assessed for liver disease and whether they have normal liver function tests or whether it's elevated, and again be linked to care. And if the patient has a normal ALT and negative viral load, but at follow-up is known to have raised ALT, then consideration for repeat viral load testing should also be taken in the clinical context. I thank you for your attention.
I'm now going to cover what's new in the treatment of hepatitis Delta. A little bit of the current and the future therapy. And remember, future therapy is going to depend on where you are. So you've already been exposed to the fact that Delta's disease course is a little more aggressive. And this is really meant to remind us that the impact of therapy is to prevent disease progression. So the most important reason to engage a person into treatment is to stabilize their disease, prevent cirrhosis, prevent decompensation, and prevent liver cancer. These are the European guidelines where they outline that pegylated interferon is the only currently approved therapy for Delta. That remains true in some countries, but these are from 2017. I'm going to show you that that's no longer true for a lot of Europe. It is a reminder that if you are going to use pegylated interferon, you'll want to use it for at least 48 weeks. And anti-hepatitis therapy for hepatitis B is only really needed if the hepatitis B is actually detected. So if you have hepatitis B viremia, you're going to use an antiviral therapy for the B also. New therapies are in development, and it's really important to weigh the risk-benefit ratio. If you think that you might have a patient that's going to be eligible for a new treatment soon, you might not want to start interferon monotherapy. And then, although our guidelines do recommend at least 48 weeks of monotherapy, I will outline that there is some data showing prolonged pegylated interferon can sometimes induce better virologic response. So as a reminder, we need realistic expectations. On-treatment virologic response rate is as high as 47%, but also as low as 17%. And when we look at individuals 24 weeks after treatment cessation, only 25% remain hepatitis delta RNA negative. And so that's not particularly great outcome if you're going to look at a year of therapy that might have significant side effects. On top of that, if we follow these patients far out, about 50% of these initial responders will again relapse. So it's really important not only to have realistic expectations, but to try to follow these patients long term, because their response is not always durable. It's also important to recognize that antiviral therapy for hepatitis B in our current state, anything obviously that affects surface antigen levels might change, but our current antiviral therapy for hepatitis B as well as ribavirin do not have effects against Delta. And now this is what I alluded to. This is a study that is not for the faint of heart. It looked at prolonged use of pegylated interferon. This was a very small cohort of 13. And it did show that with prolonged duration of treatment, you did capture ALT and AST normalization in some, and more importantly, surface antigen loss. However, this is by far not standard of care, and it would be very challenging to do in someone who has more advanced disease. And it would also be challenging to do in someone who actually doesn't have advanced disease, given the side effects. Plus, response rates are not always predictable, and this is a hard course to gain that surface antigen loss. So let's look towards the future. This is a cartoon looking at replication, and there are multiple places in the hepatitis delta lifestyle that are worth emphasizing. Firstly, anything that binds replication, binds entry is going to be effective. And here we have bulevirtide as one of the agents in development. We know that pegylated interferon lambda is being looked at. We know that there are a lot of markers or a lot of agents that are also effective against hepatitis B that I'm not going to discuss today, but things like NAPs or siRNAs, anything that's going to eliminate surface antigen might have relevance in Delta therapy. And again, I've touched a little bit on lonafarnib, which decreases prenylation, which then affects assembly. So just a reminder, I said that there was no other therapy other than pegylated interferon, and you can see in July of 2020, the EU actually approved in a conditional authorization bulevirtide or Hepcludex for individuals appropriate for antiviral therapy for Delta. I want to look at a little bit of the data behind that. So this is the phase 3 randomized open label trial of bulevirtide monotherapy in patients with Delta. Patients could have had advanced disease, and that's really important because when we look at the epidemiology, as was described, our Delta co-infected patients get cirrhosis at an earlier age and are higher risk for liver cancer. And so we didn't, it's important to make sure that you're not excluding those with cirrhosis. They did have to be relatively well compensated. They had platelet counts of 60,000. You could have co-infection with HIV, but it had to be controlled. And you can see that here they used prolonged exposure to 2 doses of bulevirtide, as well as a control arm that had access to bulevirtide after 48 weeks. And the endpoint was really virologic response described as a viral load reduction of at least 2 logs, as well as ALT normalization. And then secondary endpoints were things along with elastography changes, undetectable levels of RNA, not just that 2 log decline. When you look at the efficacy of this, and this is the, results that were released at EASL, you can see that the combined results, which was a 2-log decline in ALT normalization, was about 45 to 48%, and only 2% in the control arm. It was not statistically significantly different between the two doses. When we look at those that had just declines of delta viral load of 2 logs or more, the efficacy now was a little bit higher, 71 to 76% at 48 weeks. And although we like ALT normalization, I think most of us like antiviral response. But when we look at undetectable levels, even after 48 weeks of bulevirtide monotherapy, only 12 to 20% of individuals had hepatitis delta that was undetectable. And so that might increase with more exposure, but that certainly wasn't as exciting as what we would have hoped. Now, this is looking at safety and efficacy of 18 months of bulevirtide therapy in the French early access study. It's important to know that in this study, patients could either receive monotherapy or combination therapy with pegylated interferon. And because this was an early access study, this was not controlled. This is really at the discretion of the provider. On top of that, therapy could be modified so that if you started on monotherapy, but the provider thought that you needed interferon added, that could be done. If you started on combination therapy with pegylated interferon and bulevirtide, and that was not tolerated, there could be dose reductions, they could drop the interferon. And so really this was truly an early access study, and disease treatment decisions were based by the providers. But when we look at this, you can see that the bulevirtide monotherapy and 2 milligrams did show efficacy when we're looking at 2-log declines or undetectable levels of hepatitis delta. So the 2-log decline occurred in about 60% across the board, and undetectability was a little bit better here at 32%. When you looked at the combination, those that received some form of bulevirtide with pegylated interferon for 12 to 18 months, here the efficacy is a little bit higher. That 2-log decline went all the way up to 95% in those that had at least 12 months of combination therapy and then continued bulevirtide, and was as high as 77% in those for undetectable delta levels. So it really suggests that we may not fully understand how to use this, but either monotherapy with bulevirtide or combination with bulevirtide plus pegylated interferon might be a very good opportunity for some of our patients. And this early access therapy did allow patients with significant but not decompensated disease. Now, there were studies looking at patients with more advanced disease. And so in this real world study, these individuals had very advanced cirrhosis. You can see that they had to have, that some had compensated cirrhosis, but they had to have varices or elevated FibroScans, thrombocytopenia. And even in this more fragile group of individuals, bulevirtide monotherapy led to pretty good virologic responses, as well as normalization of ALT and a little bit lower combined response, as one would expect. So really starting to see the fact that we might have significantly important treatment options for our patients, even if they have more advanced disease. Now, I want to turn to pegylated interferon lambda with lonafarm and ritonavir. So this is the LIFT hepatitis D study. So this is PEG lambda, not pegylated interferon alpha, like the bulevirtide studies were combined with. And you can see in this study that looked at 12 to 24 weeks that there was a significant decrease in viral load. We're just getting information on this, and this is pretty exciting. Now, this study did have improvement in ALT in those that had virologic response, but if you did not decline your virus much, the ALT didn't really improve. And there are some significant safety signals here. So that lonafarnib with ritonavir does have a lot of gastrointestinal side effects, and although lambda has, in theory, less side effects than pegylated alpha, it still does have some side effects. And so this was a therapy that was not perfectly well tolerated, although not many patients required discontinuation of treatment. You can see that there were 5 discontinuations, 2 dose reductions, and those discontinuations were for hyperbilirubinemia and a little bit of ascites. More importantly, when you look at durable response, so remember that the bulevirtide studies were looking at really continued therapy, whereas the lambda lonafarnib study looked at a finite therapy with discontinuation. There was a 23% durable response at 48 weeks, which meant that lots of patients did relapse. But if you had declined your virus to below detectability, 5 of these individuals did have prolonged virologic response, which makes this a viable option for some of our patients. Now, I just want to briefly look at a very basic research study. And although, bear with me, I think that sometimes basic research can be a little complicated, but this is really exciting. And it talks a little bit about why maybe one of these monotherapies is not going to be good enough. So this looked at cell culture, and they exposed the cell cultures to Delta. And when they treated the cell cultures with either pegylated interferon or with interferon alpha or with either of the 2 therapies, bulevirtide or lonafarnib, you could see that there was impact on virologic replication. But more importantly, some of the patients actually had Delta that transmitted by cell-to-cell division, not necessarily through virologic uptake, so that it suggests that there's 2 ways of Delta reinfecting or infecting cells. And when we looked at cell cultures, some of the interferon therapy was important on those individuals that had cell-to-cell transmission of their Delta. So what does this mean? Well, when we look at this, you can see that although lonafarnib and bulevirtide might be very effective, used as monotherapy, you can see the pink areas are replication. They were not as effective in decreasing replication as combination of bulevirtide with interferon or lonafarnib with interferon. And when we combined both agents, bulevirtide and lonafarnib, you still saw that cell-to-cell replication. So it really implies that although not all patients are going to be able to tolerate interferon, there might be some role for interferon depending on the mechanism of action and how we're going to try to approach the long-term outcome of therapy. All right, so I want to round out this program with some conclusions. A reminder that Delta is a significant disease worldwide, with up to 60 million individuals infected with Delta globally. It is a defective RNA virus, so it really needs a hepatitis B surface antigen for viability and for infectivity. And if we can eliminate hepatitis B surface antigen through either functional or sterilizing cure, then this is going to allow us to also impact Delta. It is a more severe form of viral hepatitis, and that co-infection, superinfection do cause significant morbidity and mortality. On top of that, rates of cirrhosis and liver cancer are much higher. There are 8 Delta genotypes, although we do think that the drug pipeline is going to be effective against most. And until recently, there were not really that many therapeutic options outside of pegylated interferon. So all hepatitis B surface antigen positive individuals should be screened for Delta with anti-hepatitis D or hepatitis D antigen, depending on what's available to you. If you are anti-Delta positive or antigen Delta positive, you need that Delta PCR. That's going to let you know if you have active replication. You also need staging. Do not miss cirrhosis. And any patient who is Delta PCR positive is at risk for clinical complications and should be considered for therapy, especially if you might have one of these agents available to you. They should also be not only considered for treatment, but they need liver cancer surveillance, given that their liver cancer rates are so much higher. So again, I want to thank you for joining us. Please join all of the WGO activities for World Hepatitis Day and screen. The only way we're going to be able to eliminate hepatitis C, hepatitis B, hepatitis D is to identify those with disease, vaccinate against vaccine preventable infections, and treat those that have active infection. Thank you again.